Dr. Hopkins, a range of questions from core participants. The first relates to the reference you made to loss of corporate memory and the disadvantage there can be in relation to that. Is one advantage of publishing information that you create a public record that can then help avoid the loss of corporate memory for the future?
I completely agree, and that's why, since UKHSA has started, we've been very clear about publishing things timely and frequently, and ensuring people are updated, as I think, especially now with the way that we can search information, having it on gov.uk is an essential component.
In relation to the recent monkeypox outbreak, you spoke of collaboration with the British HIV Association, British Association for Sexual Health. Was there contact between UKHSA and NHSBT over the outbreak, and were there any concerns about potential impact upon the national blood supply?
So actually, we haven't really had time to discuss NHSBT. So actually, we have a joint team working across UK Health Security Agency and NHSBT, both epidemiologists and virologists. And they were very, very closely involved in all stages of monkeypox, from the assessment of what the risk was to actually ascertaining whether the questions and screening questions were the appropriate to remove that risk, to identifying any individuals who may have given blood in a window period. So actually very close working relationships.
In terms of the briefing notes that you referred to, are those a regular publication?
So they are not a regular publication as in a daily or weekly. We actually have a health protection report that we publish on a regular basis, at least monthly, that often includes updates on incidents that we're managing and output statistics reports that we're publishing. The briefing notes are irregular and are there to inform people when something happens at short notice and give regular updates and information, both information on what to do from an operational and technical viewpoint, but also ensuring that the NHS and the public health system's informed.
And is there more, do you think, that could or should be done to disseminate information that you've gathered, UKHSA has gathered, to clinicians?
So, I mean, I think there's a balance. So firstly, as somebody who receives lots of emails, if you receive lots and lots of emails, you can get fatigue in those emails. So we have to have this balance of where we think it's really important that people know this and will read it, and how we do that through CAS alerts, National Patient Safety Alerts, is quite critical. If we overload people so that they become a daily occurrence, then the worry is that they wouldn't read them. I think that's why we try and have a balance in having a social media presence, both as an organisation, but often many of us as individuals are there as well to provide that information. Working with professional societies and organisations and doing presentations at their meetings, as well as working with them so that they can help inform their members, working with the Royal Colleges, and then technical reports and outputs. So I think there isn't a simple way, and I think an alerting system might result in alert fatigue if we alert them every time we thought there was an issue and we needed to do that. So I think it is trying to find that balance, and I think we've got it better now than we perhaps did previously because it's easier to do it, but we can always get better.
And what is the CAS system? How does that work?
So I think you might have heard of this a little bit from Dr. June Rain yesterday as well. So it's a national alerting system that allows for a rapid cascade of information from national organisations, MHRA, NHS England, Department of Health, particularly the CMO's office, and ourselves at UK Health Security Agency. And it provides an email alert to anyone who's registered for the system, and particularly to organisations who can then cascade within their organisations, primary and secondary care, independent providers, prescribers. And so it's a way of informing the system where they can then use their internal cascades to continue to do that.
And do you have any sense of how effective the systems are for information arriving ultimately with GPs where relevant?
Yeah, I probably have less knowledge of that. I know that, for example, in the CAS system, each GP practice has to be registered on the CAS system, and was, that was delivered, I think, about a year ago, where they were ensured that they had to ensure their practice was registered, so that they would get a notification, and then they're responsible in that whoever that generic email or that email is informing the GPs and their practice from that. As a hospital practitioner, I'm on that system, so I often see if I've got the 360 from either a briefing note we've sent out as an organisation, have I got it to my NHS email, or have I got the CAS alert? And that's a first thing that I do when we've sent something out, is check that I've received it at the other end. And I think we should consider whether we've got better audit processes to know that how well things are disseminated and how well organisations disseminate internally as well, because it does sometimes, or can sometimes, feel that information goes out but doesn't always reach the people who need to see it.
You talked about, in relation to the duty of candour, your sense of how things had changed. Is that a reflection, do you think, of the fact that the duty of candour became embedded in statute? Has that made a difference?
I think it has. I think doctors personally have always had a knowledge of the duty of candour, but they may have felt difficult to deliver that within an organisational capacity. And I think that the statutory effect in ensuring that organisations had a duty of candour as well has actually helped that progress forward.
Then I asked you about inequalities, and you talked in particular about my reference to protected characteristics. When considering inequalities during its work, does the UK HSA consider socio-economic inequalities as well?
Yes, we do. We particularly look at the index of multiple deprivation, which is done down to a very small unit of level at a geographic basis. So we look at individuals' postcode. We often don't have socio-economic class as referred to by the Office of National Statistics, but we look at other associated metrics and include that.
Now, I've been asked to ask you about the impact of underfunding in the NHS and staffing problems in the NHS. I'm not going to ask you in quite those terms. You're not accountable for the NHS as an overall entity, but specifically in relation to the work that UK HSA does. The inquiry's heard some evidence from its Public Health and Administration group with concerns expressed about insufficient numbers of public health physicians and insufficient resources, in particular at a local level in relation to public health. Are there any concerns that UK HSA has about either funding issues or staffing issues as it directly relates to the work undertaken by UK HSA?
So we've had a reduction in funding in many years, as many parts of the system did in public health. I think that changed with COVID, and we've had an increased funding allocation from that. I think we believe it's very important that we're funded adequately to deliver what we can and to have that operational resilience, and we make the case constantly to ministers. At the end of the day, when ministers make the decisions and final decisions about funding, we have to work within that envelope and deliver the best we can for that envelope that we have. So it is a balance of making our case very strongly to ministers on why we need our funding, and then getting on and doing our operational delivery with the funding envelope that we have.
And in relation to the specific point about the sufficiency of public health clinicians, is there a problem in relation to not enough people going through that route?
So I think, first of all, I would say that we need a multidisciplinary workforce, and public health physicians are one component, and there's also non-medical public health specialists as well, which has been a major route that has been taken forward to recognise the multidisciplinary route. We also have pharmacologists, infectious diseases and clinical microbiologists, and would recognise all of those workforces in what we need to deliver, because we need expertise in diagnostics, we need expertise in surveillance, expertise in clinical psychology, how we communicate. And therefore, I think that looking just at one specialty is probably the wrong piece. For us as an organisation, as a new organisation, we're very much looking at what are our workforce needs, but also what are the workforce needs of the system around us. And we do recognise that the changes in funding and the reductions in funding in public health to local authorities does change their capacity to deliver, and working with them to recognise and understand where we can support them, but also where we can help them make the case for their funding is an important part of the work that we do, recognising at the end we deliver within our envelope.
Just a question about ProMed. Do you know what led to its establishment in 1994? Was there a particular trigger?
I'm afraid not. I was still a medical student then.
And does it receive any kind of funding, or is it purely a voluntary organisation?
So it does receive some funding from other organisations, and it receives funding from individuals who subscribe to it on a voluntary basis, but it does not receive major amounts of funding for it to continue.
You indicated that there would be occasions where reports would need to go up to the Department of Health. When is it regarded as necessary for something to be escalated to the Department of Health?
So, I mean, firstly, I would say that we have, within the organisation that we are now, have a good close working relationship with policy colleagues in the department. I personally talk regularly to the Chief Medical Officer as part of our roles in our organisations. And we would inform the Secretary of State's office for any impending publications that we were going to do, especially if they were out of sync with our normal schedule. And we would inform the department of any new and emerging risks that we were detecting or new and emerging threats that we were identifying, in order to initially inform, but then potentially also to consider a range of actions that might be needed. That's done on an ongoing basis. We submit to the Secretary of State's office on a weekly basis on a variety of updates and threats that we're identifying.
On the issue of the patient notification exercise, you said your view was that the default should be for a patient notification exercise. Is it your understanding that that's the widely shared organisational culture, or is that your own view?
So I think it is the widely shared organisational culture. It's the culture that we have developed over many years, and thinking that's the best approach.
And then when I was asking you about patient involvement, you talked about UKHSA being one step removed, and I think that's evident from your evidence, but that you work directly with patients in some areas. And I think one of the examples from your evidence is where there's been direct laboratory work undertaken by UKHSA's own teams. Are there other areas where UKHSA is directly working with patients?
Well, I think within our local and regional teams in particular, they would work with patient groups. So particularly, for example, we would look at groups of ethnicity or religious background in terms of vaccines, and how we can understand why people might not wish to have vaccines or wish to have different treatments, and understand how we can communicate better, or what are the better ways that things like vaccines can be delivered. And then obviously the delivery of vaccines sits with the NHS, but we would work with the NHS to optimise that delivery.
And then last question, when I asked you about potential weaknesses within the system, you talked about how the structure outside the organisation had changed and is under pressure from sources other than infectious diseases or external threats, and said maybe words to the effect of maybe infectious diseases feel less important. What gives you that impression, particularly after the pandemic?
Well, I think it's probably less so with the pandemic, where they are now in stark focus again, and not just the COVID-19, but also other respiratory viruses, and people are talking about them regularly. But I think, this is only one component of medicine. I think a lot of the components of medicine deal with more chronic diseases in other areas, particularly diseases that cause the main causes of mortality and morbidity: cardiac disease, lung disease, neurological disease, dementia. And so, quite rightly, the system spends more time dealing with many of those than infectious diseases threats, many of which have treatments and have got ways forward that we know what we're doing and dealing with.
Thank you. So those are the questions I'm proposing to ask from the suggestions from core participants. Do you have any questions for Dr. Hopkins?
Thank you. Well, I just have one question to explore with you. It has effectively two parts to it. But it comes out of your observations that when you make the best case you can to government for funding, and then get on doing your best with what they give you. The implication being that there may be a gap between what you're asking for in your business case and what you get when the spending round is determined. And similarly, in dealing with local public health, you described how the shortfalls or limits on funding which they have has affected the delivery there of the services which they might otherwise offer. So the question, first of all, looking at the UK HSA, is this. What if you had the business case accepted in full? What would you most like to see improved in the services which you are currently offering?
So I think, firstly, to say that I think that throughout the pandemic and more recently, we have had an uplift in our funding and have been delivering to a much higher capacity and capability than we've been able to do before, and I hope that continues. I think we'll all pick different areas, and I expect if you got different people in a room, people might pick different areas. I think the areas that I'm particularly spend a lot of time thinking about are how we can detect infections better, because obviously new and emerging threats or the infections that are there. So what are the diagnostic tests that we have? How do we look at those better? Two is how do we have the best data possible? And a lot of our data comes from the NHS or voluntary notifications from clinicians. How can we optimize that so that people inform us of infections at the earliest possible opportunity and that we have the best lead-in time to be able to investigate and understand? That we have within our organisation the best systems to be able to interrogate all of that data so that we can detect threats quickly and easily as they're emerging, or new and emerging problems that might have been there in the past. And finally, that we're able to deliver interventions. So those interventions often will be delivered hand in hand with the NHS, but where there is an evidence base for an intervention, and especially where that evidence base is cost effective or clinical effective, that we are loud at championing what those are, but that those are the places where I would like to see funding delivered in the future.
So the funding would be to do something in those areas to achieve those objects?
Exactly, whether that be vaccination, whether that be doing a test for individuals to find them in the first place, or to deliver a treatment. And I think the challenge for some of this is very much often where we provide the science and the evidence base, but much of the delivery of those direct to individuals, to patients, comes from the NHS.
And the second part of the question related is what improvement in public health more generally would you see as desirable if the funding were available?
So I think that in terms of the public health system, I think connections in the public health system and having time to connect, because actually having those personal relationships and contacts and knowing each other and trusting each other is essential for a system to work well, particularly such a system that is at multiple local levels across the country. Secondly, excellent training, both training for the individuals undergoing training right now, ensuring there's enough training places to allow them to have a wide range of experiences in training to give them a holistic view of the public health specialty area, but also the system. And finally, when they are trained and they are considered a consultant or a specialist, that they have opportunities to continue to train and develop and network and have the opportunity to deliver that effectively, so that they have enough time to reflect on what's happening and challenge the status quo and deliver an constantly improving system to the future.
So the first connection really is looking at the personal aspect of it and recognizing that the people who operate in the system are really most important to its effective delivery, is it?
Correct.
And the excellence of training, obviously that speaks for itself, but the opportunities to train and develop, is that, do you think, related to there being a well-recognized career structure so people can come into the field of public health and expect not simply to stay where they are, but have opportunities to move on and upwards and have a greater influence for the good?
I think so. So the career structure can often mean that certain individuals can come in and stay in a very similar job for 20 or 30 years. And I think that being able to move from job to job and post to post to experience different aspects of the system brings a lot of additional benefits to the system in general, but also to that individual, to keep them challenged and rewarded for their job, as well as ensuring that they provide the best public health knowledge to the system and to the individuals who need it for a very long life.
And presumably not only keeping them challenged, but keeping them challenging.
Exactly.
Which is another aspect you emphasised, the need to reflect and challenge.
I agree.
So looking at effectively received wisdom and seeing if it still operates.
Exactly.
Yes, that's most helpful. Thank you.
Dr. Hopkins, was there anything you wanted to add?
So, firstly, thank you to the Infected Blood Inquiry for giving me time and allowing me to reflect on many things in the organisation. I look at the individuals who are infected and affected in front of me and online, and I'd like to express my sympathies for everything that has happened to you over the last 40 years, and apologies for any of the system failures that have happened.
Thank you. Sir
Well,
Brian.
thank you for your part in helping us. It's been a very interesting morning, as you will have understood from the questions which have emerged. So thank you very much indeed.
So we then break now until 2 o'clock, so a longer lunch break today, and then we'll hear from Professor Melville on
Yes.
behalf of the GMC at 2.
2 o'clock.